Good afternoon, everyone. Today we're joined by Dr. Williams, Chief Medical Officer of Health for the province of Ontario. As per usual, he will offer some brief opening remarks, at which point we'll turn it over to the phone line for questions from media. Dr. Williams?
Yes, good afternoon. Data and reports. So we're going to be talking about two or three things. One is where we're at, because this is Thursday. How has the week gone? What are we looking at in going to the weekend? And how are we doing as a province overall as we progress through stage 3? As you know, this is our one full week with everybody at stage 3. And leaving out Windsor and Essex, that means everybody's at 2 weeks or more. So we are trying to see how we have been doing. As some people were anticipating a lot of upsurge in the cases. In that, we have seen some outbreaks, and they have been quickly contained in different settings, either occupational, sometimes some communal group gathering or congregate, but they have been identified and moved on. And there's been further testing coming out of those where they've identified more cases out of the contact tracing in that light. And so we see some examples even in some of our farm areas where they may find 1 or 2 cases. When they test the rest of the people, they find others. So we're actually going out searching for cases, not just waiting for them to passively be identified. So that, in a way, it keeps our numbers from dropping down precipitously. But to me, as I said before, that's reassuring. If we went down to really low numbers for a number of days, I'd wonder how assertive our case contact management is doing, because we still want to search out those and to identify as many as possible and contain it. And that's been our program here in Ontario. Our data today, we have 76 new cases. Now, I'll put a caveat on that. It's nice to think of 76 because we've been over 100 for a couple of days. I will say that in that number there's 11 health units who are transitioning and dealing with some numbers and issues with their data systems as they're moving to new systems. So 11 health units have not reported. So I would say that 76 is probably not an accurate number. The general number of what those other 11 tend to report, because they're not our biggest ones, is somewhere between 10 to 15 total in a day. So I think we're probably more closer to around 90 or just under 100. So while sounding good, I would put a little asterisk beside that and wait and see what our data is when all the data is entered and the systems are up and running. So we have more resolved cases, 91%, 37,291. And still, unfortunately, 1 death. But the number of deaths over week has continued to drop, and that's really encouraging. Most of the cases are still in our large health units. Toronto Public Health with 21, Peel with 19, and Ottawa with 11. Hospitalizations and patients in ICU and ventilators continue to decline. The number of patients in ICUs remains stable, and we're waiting to see that number drop even further. Testing, again, over 25,000, nearly 26,000 tests were done, and our positivity rate was 0.6. We've been continually staying around 0.5 to 0.7, not jumping over 1%, not even getting close to 0.9, which we were a few weeks ago. We've dipped one day down to 0.4. So we want to see that number stay or drop down a bit lower, and that's an encouraging direction to note as well. So over week, our cases continue to decline. And I was looking at our data, and well, we see the highest percentage of cases right now, because we're dealing with very small numbers, in our 20 to 39 age group. I know the group has taken a fair amount of criticism of that. I think that when I look at the data overall, the number of total cases in that group is not huge. So I'd say there's a lot of in that group are adhering and staying to the standard. So I'm not saying that is a message for negative for everybody, but those that aren't should still continue to use constraint and stay at the task as we go forward. So I'm not totally negative in that age group, because I've seen some of their data over time, and they performed fairly steady as a large group, population-wide, fairly well. And nevertheless, there are some who are having difficulty and are either not choosing not to stay to the task of the measures, be it the distancing, the masking in public, the social circles, hand hygiene or staying home when you're ill, and reporting and getting tested when needed. So, and our deaths are continuing to go down. Most of our cases are identified are either in close contacts or in management of those ones there, and some are still in the non-epi linked because we're still working out the investigation and completing that task. Still a few with travel related, and we're monitoring that situation in live time. So what does that mean? It means right now we're seeing cases, and we see sometimes certain parts of the province seem to have a high number for a bit, a day or two, because they're dealing with an outbreak, a contained outbreak within a community group, within an institution, and that because they not only find out the cases, they actually do some further testing and find some other cases. So they have identified those. That means for a day or two, their numbers go up, and then they come back down again. And so this containment process is continuing, and that's what we need to do, and that's encouraging. So I said at the outset, when we're looking at how this is progressing, as we move through stage 2 to stage 3, there was much apprehension that the numbers would take off. And we have not seen that. And I think that's because Ontarians still take this seriously. They are doing it. And high percentage masking, doing the distancing, keeping the social circles. Some have doing some alterations. We're hoping to come back with some further recommendations around social circles as we progress and have now getting completed data for stage 3. Proper work by various institutions, restaurants, others, adhering to those rules, trying to monitor that, trying to do their best at that, being checked on if they're not, and trying to keep everybody on course to stay at this. Because we're going to have to do this for a while as we progress through, as more things open up, as more things that you used to have and used to, you can access, but with a limitation, and staying true to those public health measures. We want stage 3 to get through a number of weeks because our next phase, much in the topic of all discussion, is back to school. And that's what we're trying to work at right now. And part of that is that the preparation we've done all through our stages 1, 2, and 3, as our population-wide, are carrying out what we call fairly significant and consistent infection prevention control practices. That's what it is. It's not these scientific complex ones. It's these ones that you do again, do well, do all the time, that makes for a successful infection prevention control program. And the same way you've done that while you, your family, and your children have been around, out in the public, getting potentially exposed, you've kept that number down. And I think what we're trying to do now is to say, can we translate that and saying, what does that mean in the school setting? And we're hoping, as we get materials out and ready and going, to be talking to you, the parents, to the students, to teachers, and to the large group, grandparents too, about what does infection prevention control, IPAC, mean in a school setting? What does it mean in elementary? What does it mean in high school? What does it mean in JK versus grade 7? How do we do that? And as we're ramping up our public health nurses to go out and connect and to carry out that knowledge translation, that education, we're hoping to be able to pick up on that. So we want to talk to those things again, same as you did before with your children. How do you prepare them for school? You talk to them about what they're going to experience. You talk to them about what they need to do, how they're supposed to behave in a school. That means you want to reiterate those public health messages. I find sometimes the very young ones are very good at it. They remind us what those public health measures are. And they're pretty diligent about it. Washing hands, physical distancing, wearing masks at the right time in the right way, and behaviors, grouping, proximity. Even the young ones are very good about it in that sense. So we want to make sure that that is carried out because it's a collective action as you fill these new groups and cohorts in the classes, in the cohorts, in the students, in the high schools and different ones. There's going to be variations and different ones in different areas. We know that because not all schools are identical. And we want to work with the parents to work with you to say, you're engaged in this infection prevention control practice. The better you do it in the community, the less community transmission there is. If there's no transmission in the community, the happenstance of your child picking it up by just walking into school is quite unlikely. Nevertheless, we're not saying it's totally risk-free. We want to be on the outlook for it, same as you are, and with the teachers and that. So we want to be monitoring the situation throughout the fall. We want to be ready to respond if we need testing. When we do the testing, how quickly do the testing. These are all things we're working out right now. So that you as the parents and others and staff and that can be reassured that if there is some issues, because we're not going in saying we don't think there will ever be any issue, we want to see if there is an issue, assess it quickly, determine what it is, wall it off, coordinate it, and communicate it. And we have to do all those things. So we're going to be coming back and talking about that as we go forward. The thing to remember that I've been encouraged by some of the discussions on the media is a lot of experts are coming in with the data, and that's what we've been trying to tell you at these meetings and these press conferences. We're giving you the data. One, that you know what it is. You know what's in your situation. And if you look at the data, you've heard us say that the number of children under the ages of, especially under the ages of 14 or 10, that get serious conditions related to COVID is very, very low. We haven't seen that. Experts haven't seen that in other countries either. That's the data. That's the information. But can they, like they do at schools, can they bring other things home besides their homework? Yes, they could. And we want to understand that better. We want to make sure that doesn't happen. We'd rather just bring home the home assignments and the work materials and that and the empty lunch boxes and not bring home COVID. And so we're going to be working hard with you to make sure it doesn't come in and make sure it doesn't come home. That's what we've got to work at. And I think as we've done successfully with stage 1, 2, and 3, I think collectively Ontarians, we can also do this as well. Because our children, we understand the risks, and from our medical experts and our psychologists, there are risks of staying out. And we want to make sure our children are well equipped as they proceed through in their development and going ahead in the future. So with that, I'm saying stay tuned. We'll come back with more information with you in this regard. And with that, I'm going to open up for questions from the media.
Great. We'll go to the line for the first question.
Your first question comes from Dan Drago with Global News. Please go ahead.
Hi, Dr. Williams. A company has started marketing antibody testing to people concerned about exposure to COVID-19. Doctor, is this even legal, and is this something that you would advise Canadians to consider getting?
In this time of evolving science, our experts, our lab experts, are reviewing the data, reviewing the techniques. There's many coming out. As compared to SARS, the amount of research going on is huge and extensive. There is good information and there is sometimes not so good information. As a result, there is strict methods around licensing. You have to pass some federal levels to get it licensed from the Bureau of Biologics. And then there's testing back here in our province to say, how confident are we in that testing? So if we think it's a legitimate test, we would tell you. And again, it's like the thing buyer beware. And so we're watching this very carefully at the different modalities of testing, with serology testing, as you're alluding to there. How good is it? How effective is it? What level of proof of ongoing immunity does it have? And if our national committee, which was announced on nearly 2 months ago under Dr. Evans, is saying we're still asking those questions. If they don't have definitive answers, I'd be very surprised if those companies can promise their clients that they have those definitive answers. So let's rely on the experts. Let's do the proper due process, because misinformation can be as harmful as no information. And we want to make sure you have the correct information and the correct advice if we're going to undertake doing this, because we want to rely on that data to make decisions, and you want to rely on that. So you have to stay tuned and ask the right authorities, is this a legitimate test or not?
Follow up?
No, we're good.
Okay. Next question.
Your next question comes from Randy Rath with CHCH TV. Please go ahead.
Hi, Doctor. I'm wondering, what's your guidance to school boards when it comes with dealing with a teacher or a student that tests positive for COVID? Should the whole school be shut down? Should the classroom be shut down? And the student sent home? And for how long? What's your recommendations?
So consistent with what we've done in other congregate settings, for example, if you're at a long-term care home and a staff member tests positive, or 1 or 2, they may have brought in from the community. If we have cohorts, and that's been our process, that teacher supposedly has maintained proper, let's say it's a teacher, staff member, has done the masking and proper things, and they're only in with this class or cohort, and we are concerned, we would want to assess the rest of the ones in that cohort, much like we do in the area of the long-term care facility in the same way. So we're being consistent with our practice, because it spreads by aerosolization and air spread, and so the ones around that in a contained airspace for a period of time, knowing they're probably wearing masks, there's been some distancing, and see just in case there's any breach. So we would purport to say, in that case we have a case in a cohort, whether it's a student or a teacher, we would want to then test the others in that cohort and give advice of what they should do while they're waiting for testing, the same we've done with others. If you're a contact of a person that's being investigated, even out in the community, you don't have to go in isolation, but you do have to self-monitor. You wait for that person to be tested. While they're being tested, they're asked to be in isolation while they wait for the test results. That teacher, that student, if they're being tested, they're out and they have to wait for the results, and then they get tested. If they come back positive, then anyone who's been in close proximity to that person is now, as similar we've done all the way through, they are now a contact of a case. Then they have to get tested, and then they have to maintain isolation in that sense until they get those results back. And so we want to make sure we can move on that quickly, test the others, rule it in, rule it out as quickly as we can. Because the chance of transmission, especially if you've been doing cohorting, distancing to some extent, masking, other things, and hand hygiene, is probably quite unlikely. Nevertheless, we would want to make sure we can rule it out as quickly as we can. So that's generally the general process, which, if those who have been following all the way along through this, saying, we've heard this before, this is fairly familiar.
Follow up, Randy?
So would those people that had come in contact with an infected person, would they face the prospect of a mandatory test? And if not, would they be put in a period where they're isolated for 14 days?
So as we had before, if you're we call a significant contact, not just that you pass someone in the street, that you've been in that cohort, in that group, it could be your social circle at home, or it could be in a work situation where there seems to be, by public health, a significant potential period of contact and sharing, that in that time we would request that you get tested to rule it in or out and stay in isolation until such time as we rule that out. If a person says, I refuse or I don't want to get tested, then you're correct. What we've done in the past is, well, you could then stay out for the 14-day period and get quarantined if you choose not to be tested, which would be, if you had a group of 10, 15, or whatever, 20 in a group, and everybody else was negative and you're refusing to get tested and you're staying out 14 days, the chances are you probably would have been negative too. So we're trying to encourage, because we're trying to go towards some different types of testing if we can, less invasive, especially with children, more like the anterior nasal swab. And we're looking at that because it is much easier to administer and less invasive, I can use that word, as compared to the nasal pharyngeal swab. So I would hope that everybody would want to get tested to rule it in and out as quickly as possible. But you're right, that's what we've consistent with other approaches. Those who have been significant contacts, who choose not to get tested, would have to stay in quarantine for the 14-day period so we can be assured that they would not be infected or transmitting to others.
Next question.
Your next question comes from Sean Jeffords with the Canadian Press. Please go ahead.
Hi, Dr. Williams. Question for you again about schools. Wondering if the health table has considered Sentinel or surveillance testing for schools in hotspots. Is that something that the government or that the ministry would consider?
So what we're wanting to do is we certainly would do targeted testing. When you talk about a hotspot, I'd have to hear what the definition is. I hear the term tossed and handed out fairly casually. When we talk about hotspots, we want to say, do we understand what that means? And sometimes lately, when we see that a certain health unit has a hotspot, for example, they'll show the health unit as being in the last 2 days high, whereas in the days before they've been zero. And it's one farm. Does that mean the whole city is a hotspot? The answer is no. So you have to be understanding when you talk about a hotspot. If it's in a company, that's the hotspot, then I would test everybody in the company. But I wouldn't go across the other part of the district and test people because they're not in that, unless I felt there's widespread community transmission, which we haven't seen for a while, but we'll continue to monitor that. So if there was a hotspot in an area that was deemed to be high community spread around a certain area, which could include congregate settings and schools, we might choose to do some testing there. In that, if I'm taking your example and moving on that one there, but we want to define carefully with the local public health leadership and the medical officer of health, if they determine that there is a certain community area that has high levels of transmission at this time, and they have concerns, they would then recommend testing. So it would be driven on public health decision making.
Follow up.
Yes, Doctor. So I'm just trying to. I don't want to put words in your mouth here, but it sounds like you're open to that suggestion, but you're really relying on the public health unit to consult with you to make that call. Is that correct?
Well, that's correct, because the example I gave, if you have for example, you have 2 or 3 cases simultaneously in a school in different cohorts, you'd have to ask yourself, was there a failure of cohorting? Were there people not being adherent? Was there spread in the school? Could there be? You may choose to test all the students in that school. Now, that could be quite a few people. A lot of them could be asymptomatic, probably are. But you may choose, as the public health official, saying, because I can't rule out that there has been a breach in infection prevention control, and therefore I want to rule it in very quickly and deal with it. So I could do the wider testing of, say, in some larger secondary schools of over 1,000 students. You may choose to want to do that to satisfy yourself that you didn't have any transmission. So I don't think it's, I think it's somewhat consistent with the minister in that direction about wondering, are you going to do enough testing to ensure the parents and families that there has been nothing wider happening in that setting?
Next question.
Your next question comes from Christina Tenalia with CP24. Please go ahead.
Hi, Dr. Williams. On schools again, and I apologize if you've touched on this in the last few weeks, but we know that medical experts, public health officials across the country and across North America have talked about the convergence of the autumn and COVID-19 and flu season. So is your formal recommendation for parents and students that every student should get the flu vaccine, get the flu shot when it's available so that schools are safer? Or, I mean, how would someone in a school setting or even a parent be able to determine if their child has COVID-19 symptoms versus flu symptoms, since the symptoms are so similar?
Very good question, and we're trying to really address that because, of course, fall is not just flu season. Fall is respiratory virus season, and we see a large number of other respiratory viruses emerging, and we hear those fancy terms like respiratory syncytial virus and adenovirus and other ones, and rhinovirus that are very common, cold viruses, if you may. And of course, the common things are usually common. The challenge is that how do you rule it out? Because a lot of those mild symptoms in there are similar to those of COVID because it is a virus. And so that's going to challenge us to say with the parents, are we really handling this? If your child is sick, keep them at home. It was sort of a nice suggestion. It's now going to be one we really want to strongly recommend, that you don't send your child to school. As you try and sort out, you may want to see your primary care physician, your pediatrician, to get your child assessed, to see if it is an ear infection, see if there's something else, to rule in other things and rule out COVID. And they may choose to ask for testing and then get that done. But then we want you to be more proactive as compared to usual saying, you know, I may choose just to not cut the corners and let the child go to school with some illness. I really do not want that to be occurring. That's more pressure on you as the parents. I understand that. But that's respecting the other parents. And we're trying to say that in a mutual thing, that I won't send my child ill because I'm assuming you wouldn't send your child slightly ill to school either. We all got to do our part in this. And in the flu season, in the respiratory viral season, it's going to be challenging. By getting the flu shot, well, at least you've ruled out influenza. But those other ones are still there, and unfortunately, they're not going to take a break. They'll still come up and show up. But the same methods that we do to prevent spread of COVID helps us prevent the spread of flu and the spread of these respiratory viruses. They all work. And we've seen that in other countries when they were seeing the ones in Southern Hemisphere, where they were rising rapidly in their flu season, they locked down and went into COVID protection, the rates of flu just dropped right down. It's the same method. It's very logical with the droplet spread and that aspect there. Those same methods work on all of them. So are we concerned about that? Yes, we are. And that's why our infection prevention control ideas have to deal with that realm and to make sure you rule in and rule out things, and you be on the cautionary side of maybe keeping your child home if they're feeling unwell and early signs of influenza-like illness, because you want to be able to ascertain as it is, isn't, and to get it ruled in or out by either getting assessment or going to your primary care doctor or your pediatrician to rule in or out other conditions.
Follow up?
Thank you, Dr. Williams. My follow-up is, now that we are in stage 3 and moving toward phase 3, the sort of recovery phase, how close are we to allowing families back into long-term care homes and congregate settings as visitors, as, you know, family care providers in a more sort of regular, frequent capacity as we saw pre-COVID? I mean, this COVID's not going away, so is this something that is months away or a year away? Where does it stand right now?
Well, as I said before, that has moved over to the Ministry of Long-Term Care and working with their team there. I was looking at the data. It's really looking encouraging with the long-term care facilities. We're down to 11 outbreaks, and all those are very much being on the very careful side. A case, possible, you could hear outbreak, close it down. And so we're trying to get that really down. Our number of residents that are still active with cases is quite low. We're down to 3. And staff is down to a lower number. So it's all there. I think there's great concern that they don't want it to rebound back up again. But I keep asking them to say, are they reviewing their policies around that? And I wait for recommendations from the Ministry of Long-Term Care, their staff, as well as the table that deals with long-term care outbreaks and that, and Ontario Health and others, to see when they will keep opening up those recommendations. Because one thing is assuring, as your community transmission goes right down and you've had no cases in the community for a long time, there's much more of a confidence in that your staff won't get inadvertently infected and bring it back in, and that visitors, assuming they're from around the area, also would be unlikely to obtain the virus and bring it in. And that means then, of course, going to the fall, we're starting to already ramp up our plans for our universal influenza vaccination program. And one of the top priorities for that is long-term care residents, staff, and visitors and family. So that's something you can get prepared for that. So I can't give you a definitive answer to that because that's under the auspices of the Ministry of Long-Term Care. And we will wait for announcements from them accordingly. But then we can start preparing for the fall, thinking about if and when the flu vaccine is available, that you, if you're going to plan to visit, you will plan to get vaccinated as well.
Okay, we'll go to our next question, and this is our last question.
Your final question comes from John McGrath with TVO. Please go ahead.
Good afternoon, Doctor. I'm wondering about the prospects for some of the tests that have been discussed in the U.S. in terms of cheap paper-based tests that could be, as little as $1 per test or $5 per test. And I know in the U.S. the FDA is leery of them because they don't have the same sort of diagnostic standard of accuracy. Has there been any discussion, either provincially or in your discussions with the federal provincial table, about bringing those tests to Canada?
The federal provincial table and other ones, and our own labs here, are dealing with quite a large range of different tests coming from various settings, various producers who would like to have it entertained and used. Critical there, as you've alluded to, are we confident, like the FDA, in its diagnostic accuracy, sensitivity, and specificity? How does it work with our quality assurance tests, with our gold standard of our PCR tests at the moment? Because if we can't be sure it's a positive test, then all that does is make us then repeat it and do it again. So it can create a lot more testing to rule in or out what could be false positives or false negatives from those tests that haven't got the same level of standard of quality. So we have to be fairly rigorous about this, simply because while a test result may seem satisfying, but if you're led down a garden path on a false positive, that can have impacts, and we don't want people misled in that way. So we've got to be very careful on what we choose to sanction and use, because it not only affects the individual. That means if it's a positive test, are we going to respond to it? Are we going to do case contact management? That rules out a lot of resources to chase after what we hope is a quality test, and is one that's worth pursuing in that regard, because it not only impacts the resources to do case contact management. We're going to ask people to quarantine, stay home from work, and you find out it was a false positive, and that would be unfortunate. And so we have to be careful so that we do our job well, do it consistently, and do it as accurately as possible.
Okay, follow up, John?
I mean, as I understand it, the argument for not emphasizing the diagnostic sensitivity and the accuracy is that you can do, a person could administer 2 or 3 tests themselves daily, and the cumulative sensitivity would maybe not be totally comparable to a PCR test, but would still be quite high, and we could get these tests out to a much larger percentage of the population and do something closer to really sort of a population-wide survey. But from what you're saying, I take it that's not really something that you're comfortable with right now.
That would be correct, because a couple reasons. When you're talking about a population-wide survey, our numbers are heading up from 2 to 3 million of Ontarians have been tested. That's pretty big sampling. And we're hovering around 0.6, 0.5, 0.4% positivity. That means 99.56% are negative. That's pretty significant. And to say we're going to spread out farther we'd have to have some reasons why we think that by testing getting close to 3 million people, we're missing the mark. And our serial survey, when we did, has ratified that. As people saying, well, maybe you're missing. We didn't see that. Remember, we talked about a 1.1% positivity extrapolating up to maybe 5 or 6%. So the other challenge in there, and I find I'm worried about that, because people want it like a passport. So you get you get a negative test, and then I don't have to be precautious. I can do anything I want. And that's just the wrong message. And I'm really worried about that being used in the wrong way. So I think the testing positivity, we have to stand behind with our public health measures and ask the public to adhere to it, because, as I said before, our success in Ontario is that the public at large have followed this, and we have flattened the curve and continue to do that with correct information that they can trust and have confidence in. So before we open to a floodgate of variety of tests and things that then we said we have no idea what it means, that would not endear us to a lot of trust in the public. So we want to be careful with that before we want to have the reasons for it, the benefits of it, the accuracy of it, and the response to those ones if we were to do it. So there's a lot of things to be taken into the consideration before we'd approve that as part of our cadre of testing.
All right, thanks everyone. Have a great weekend.